Hopkins and NIAID actually told me the story that he, after finishing his training at Northwestern as an MD, having gone to Notre Dame undergraduate, he did fellowship training at NIAID and in the 1980s, and actually was seconded, which is remarkable for the faculty in the room. He was seconded by NIAID to Johns Hopkins. Now, we happen to have in the room, just by chance, Michael Frank, the previous head of PEDS, who at that time did this for Tom. And they haven't seen each other for 20 years. And they're meeting here today, having invited Tom to be with us. I've gotten to know Tom very well in the past year through his work leading the Hopkins Center for Global Health, and I don't think anyone would question the statement that there is no university that does more in global health than Johns Hopkins. They work in 110 countries on global health projects, and with hundreds of faculty involved from the public health school, the medical school, and nursing school. And it's Tom's Institute, Tom's Center is a facilitating center for those three health science schools. There are some chairs over here, if you like. Tom's Center is a facilitating center for those three leading schools at Johns Hopkins. Now, this is not a promotion for any of you to go there, but I will say, having spent part of my life there, that it's a wonderful institution, and Tom has really consolidated the global health excellence in these three schools. Unlike here at Duke, where we are able to bridge in our institute the whole campus, it's a little tougher there because Homewood is about 15, 20 minutes away, but certainly in East Baltimore, where these three schools are, there's probably no greater excellence in global health in the country. So we're very delighted to have Tom here, both because of his huge knowledge of global health and his leadership in the field clinically, epidemiologically, microbiology, virology, molecular biology. All of these fields Tom has worked in through his career. And I think the contributions have been enormous, both domestically and internationally. He was the founding member of the Academic Alliance for AIDS Care and Prevention in Africa, which is one of the really remarkable efforts underway in East Africa in infectious diseases. So I think you really want to hear more from Tom than you from me. It's just a great pleasure and really an honor to have him here. Mike, I'm so delighted you came. These are rare moments in our lives when we meet people from 20 years in our past. And Tom is going to speak about, and the first word should be infectious disease. He does know the difference between infection and infectious diseases. Continuous threats to global health. Tom, welcome. Welcome to Duke. I should say one other thing as he comes up here. I asked him when was the last time he was here, John. And I don't know if he told you, but he interviewed for a job running the AIDS clinic in the 80s. And that's remarkable. I guess we didn't have the wisdom to hire him then. But anyway, I don't know if you met each other then or not, but it's a great pleasure to have him here. Okay. Okay, great. Welcome. Great.
Thanks, Mike. It is a pleasure to be here, and a real pleasure to see my former mentor, Mike Frank. The story between Mike and I actually goes back to my early fellowship days. I was studying malaria with Lou Miller and was trying to figure out where do these infected red cells go when they go through what we call crisis or clearance. And Mike was by far the world's authority on clearance of chromium-labeled red blood cells. You remember those days. And I came by and he taught me how to do it, label these cells, put them into the rats, and watch where it goes. And it all goes to the spleen, interestingly. No big surprise. But it enabled us to do a whole series of experiments that actually helped define some of the immunology of malaria. And I owe a lot to Mike, including the seconding myself to Johns Hopkins. He probably doesn't even remember why I was sent there, but I was sent there to help their infectious disease training program. Get him out of here. Get him out of here. And then it was about 86, 85 or 86 that I came to Duke. David Durack invited me here. And I remember doing these interviews and talking about this new disease called AIDS. And it was what really took me internationally. While I was studying malaria, I never really had the opportunity to go overseas. And there was no funding to go overseas. It's in part why I'm doing this. Because as a student, and then as a research fellow, I really wanted to see malaria in action and never had the opportunity. And I want to make a difference for the students today that really want to go overseas. I don't care if they're at NIH or they're at Johns Hopkins or anywhere else. I would like to, at this time in my career, to be able to help those people find the funding, the opportunities, the sites to go to. And if I can do that, then that provides a certain amount of feedback to me that's very beneficial and useful in what I want to try and do in my career. But you didn't come here to hear about my background. It's just seeing Mike just brings back the whole history of how I got to where I am today. And it's been a pleasure working with Mike. We've been working together now on a consortium of universities united to address global health issues. And I'm really quite excited about those opportunities and working with Mike and hearing about the Global Health Institute here at Duke. So thank you right up front for inviting me to spend the day with you. And I look forward to many other days that I'll be able to come back and join you. Now let's see if I can move forward. What am I going to talk about? Well, besides the misspelling of the first word, we're going to talk about infectious diseases and why they continue as a threat to global health worldwide. Now, I'm going to break the talk into three parts and work our way through it. The first part is to talk about global health in general. Why are we here? Why is there a Global Health Institute? What is the global burden of disease, and where do infectious diseases fit into that global burden of disease? Then move into why infectious diseases have emerged to be a continuous problem or a continuous threat. What are the factors that have prohibited us in science and in society in limiting their spread? And they're complex, and we won't have a lot of time, but I'll give you some snapshots. And then I want to talk about the response to the continuous threats of infectious disease to global health from an academic perspective. You're all here at Duke University, or maybe from UNC if you're coming over today, or other academic centers. How can we make a difference in the field of research, clinical trials, interventions to limit the spread of HIV, tuberculosis, malaria, many of the other infectious diseases that are our daily threats to our existence? So first of all, what is global health? And why is it important? And I just took these two snapshots just to say that global health has sort of replaced the terminology of international health and have become a dominant theme in academic centers across the world. It's becoming a dominant theme in many areas of health. And in fact, another article that recently came out was this one in Lancet. If you haven't read this, I really encourage you going back. It was published in 2006, but it was an editorial and then a series of articles that involved even the Iraq War as to the role that health or global health now plays throughout various aspects of our society today. As the editor said, health's now the most important foreign policy issue of our time. And I'll add why, and that is health is now the largest sector of the world economy, accounting for nearly 10% of the global GDP. We are, as many of you know, a global society. What happens in one area of the world affects another area of the world immediately, overnight, or almost simultaneously. If the markets fail in Asia, they start to slide here, and vice versa. So that's from an economic perspective. Health is the same way, and we're going to go through some of those issues and those factors, particularly as it relates to infectious diseases. Let me give you some background or context to why we are concerned about global health. The Gates Foundation basically defines it as disparities in health throughout the world and how they can address some of those changes. What I thought I'd do is just give you a little bit of a context for some of this. First, poverty. If we talk about inequities or disparities, it basically comes down to dollars and cents. Poverty is the major issue that drives illness throughout the world today. 1.2 billion people live on less than $1 a day, 2.8 billion people on less than $2 a day, and 1 in 6 are chronically hungry. Malnutrition being one of the major causes of morbidity and mortality in children today. The population continues to grow to 6.7 million, some say 6.8 billion, who's counting, 400,000 people added each day. And in 68 countries, more than 40% of the population is now under 15, changing the population pyramid. That will become important as we get into certain diseases. You've all heard about global warming and the issues related around the environment. It is true that as the temperature of the world does increase and we change parts of our environment, we are impacting the spread of selected diseases. And I'll actually go into some of those examples. The last bullet is the one that disturbs many people, and I know some of you craning your neck in the back don't see it, but it's 31 civil and foreign wars, 35 million displaced persons and refugees, 127 failed states in 96 countries over essentially a 43-year period. This is really a disaster, and you only need to look at what's happening in Congo, a country that I've worked in for over 15 years and had to remove our teams under Belgian paratroopers at extreme conditions to get them out of the country. That was in 1991. Here we are in 2008. We're doing the same thing in eastern Congo, getting them out. Cholera is breaking out in that area as we speak. People are dying. It is an absolute. What happened in Rwanda has just moved over to eastern Congo. That's one area of the world. That happens everywhere, but sometimes not to that extreme. But there is extreme instability in the civil societies, which lead to the spread of selected diseases. And we'll go into some of those details a little bit more. I mentioned global health is a lot about disparities, and these are just some statistics I pulled out. Of 57 million deaths that occurred in 2007 last year, 10 million, or 20%, were in children under 5 years of age. 98% of those fatalities were in developing countries. 14 African countries, the current level of child mortality is now higher now in 2008 than what it was in 1990. It's gotten worse, not better. Leading causes of perinatal conditions, respiratory tract infections, HIV/AIDS, diarrheal diseases, malaria, and malnutrition. And we'll come back to these a little bit later on. Life expectancy, mostly because of HIV/AIDS, has been reversed in some countries to half of what it is in rich countries that don't have to deal with these diseases at the same level. And a deadly overlap is now occurring between the communicable diseases we've been referring to, and I will spend the rest of the talk on, and non-communicable diseases. Global health is not about only infectious diseases. Just happens to be my topic. But it's about diabetes. It's about water and sanitation. It's about injuries, and it's even about geriatrics and obesity and many other things that are priorities for health systems that don't have the resources to address at this point, leading to a struggle that goes on between those priorities. Do you put your money into vaccines to help child mortality, or should you put it into safe and clean water? You would probably say both, and we take it for granted that it's both. But in some countries, it's not. And you have to do cost-effective analysis, and where do you put your resources, and where do you put your emphasis? Difficult issues to deal with. So the global health agenda is just one snapshot shown here. We're talking about 57 million deaths, total annual disability-adjusted life years lost, which is what the metrics people all measure. And you can see any of these diseases contribute to that. In some areas, it's worse than in others. And that's what I want to just point out when we talk about infectious diseases. And we sort of call this our unfinished agenda of infectious diseases and communicable diseases. And I say it's unfinished, and people like Mike will remember this. Tony Fauci always reminds me about this, that the Surgeon General back in the early 60s basically said, you know, we're at the cusp of conquering all infectious diseases. We're about to eradicate smallpox from the face of the globe. We've got a vaccine for polio. It's just been licensed. It's out there. Everyone's lined up to take that. It really, as he said to Congress, it seems reasonable to anticipate that within some measurable time, all the major infections will have disappeared. Well, little did he know about the war of the microbes versus the humans, and how the microbes were gaining as unknowingly to what they had at that time thought we would be able to conquer with antibiotics and vaccines at the time. So where do infectious diseases fit in this global burden of disease? They make up about 15 million fatalities a year out of the 57 million. That's 26%. So if you look at the other causes of death, cardiovascular diseases as a single entity usually leads the list, followed by infectious diseases and neoplastic diseases and many, many other causes. That's for the world at large. But as I mentioned, it varies by region as to what those etiologies might be. And this is probably the best example when we look at infectious diseases. In high-income countries, infectious diseases make up only 6% of our annual fatality rate. 6%. In Africa, they make up 63%. There's no other group of diseases that rank to the same level. Now, that may change with years, and we'll continue to monitor that. But for those of you who do work, and I know Duke has a huge commitment to working in Africa, infectious diseases are one of the leading priorities. Now, there's a group of pediatricians in the group, and so I thought it would be appropriate, as we pointed out, that 98% of fatalities in children less than 5 years of age occur in developing countries. What are they dying from? Well, malnutrition, diarrheal diseases are a big list. But it's interesting, if you go and look at it worldwide, it's usually infectious diseases that make up the vast majority of those fatalities, 62% of those fatalities in children. If you take the listing then out of the World Health Report that just recently came out, and you look at infectious diseases and break them out, this is the list you end up with. So we're talking about respiratory infections leading the list at 4 million fatalities a year, HIV/AIDS at 2 million, diarrheal diseases just under that, followed by tuberculosis, the vaccine-preventable childhood diseases. Remember, the Surgeon General said we've got those vaccines, but the problem is getting the vaccines to the population that need them the most, and there we have failed as a society. With 1 million children dying each year from a preventable disease, preventable by a simple vaccine. Malaria, nearly 1 million fatalities still, mostly in children. And then we'll get into what many call the neglected tropical diseases. I don't know why they keep calling them neglected. I don't think they're neglected, but that's the terminology that everyone uses. And I work on trachoma in Tanzania. So when I'm not working on AIDS, I'm working on trachoma. And that fits in the category of neglected diseases. I like to use that to get money for it. But, you know, and that may be why that's up there. So I borrowed this from Tony Fauci, and you've seen it, I'm sure, at many of his talks. And it basically does compile a listing of numerous infections that have evolved, either were newly emerging or have been resurgent in their numbers or have newly appeared or were deliberately emerging, and that's a reference to the anthrax outbreak that we had. But you can see it's all over the world, and what we're going to talk about in the second part of the talk is how we got to have a listing like that. And I thought, for another talk, I was trying to, I work with the other John Bartlett, who always does the Academy Awards, the top 10 diseases of our lifetime or something like that. And I got an idea. I'm going, well, if that was the map, what year and what bug sort of stood out? And last night, I gave my award for 2008. It's for community-acquired MRSA, I think, which has dominated our infectious disease field and is spreading worldwide now. But each of you, you know, all the gray hairs in the room, will remember the years that these all came out. I'll never forget the discovery of Helicobacter pylori and its relationship to gastric ulcers and its reporting, or our outbreaks of cryptosporidium in Milwaukee. I mean, each of these have fascinating stories, all associated with them. And I remember talking to one group, and I got up and said, the award I'm giving for 2006 is chikungunya virus, and it is a huge outbreak that is still expanding throughout Asia and parts of Africa. So many of these you don't need any description, but it is clear that it continues to evolve, and what we might have once called an emerging infectious disease or re-emerging has now become an established infectious disease. MRSA, case in point. West Nile virus, case in point. One that hasn't, and why not, would be SARS. Reared its head, scared the hell out of us for 1 year, and disappeared. All due to good public health interventions. So we can control certain diseases if we act fast enough and with enough veracity to actually put holds on the spread of it. We haven't been able to do that with some of these diseases. So let's go to part 2. What are the factors that led to this resurgence in infectious diseases over the years? And I'm going to come back, and it's why we deal with global health. It's poverty. It's these disparities. It's issues of water sanitation. It's issues of lack of food. It's many, many issues that feed into this vicious cycle of poverty breeding infectious diseases, which then feed back to causing more poverty. And one only has to take a look at these photographs that I pulled out from various areas of poverty and social inequality that lead to breeding grounds, essentially, for selected infectious diseases. Probably the most notorious would be cholera. And when we see displacements of populations, cholera is the one that rears its head most frequently, salmonella being another one. And to emphasize this factor of poverty, if you look at what the annual per capita income is for industrialized countries, it's $35,000. For the developing countries, it's $383 a year. Life expectancy follows that. And under 5 mortality rates, 20-fold, if not more, greater in those poor countries compared to these countries. Now, if you talk to economists, it's different, their perspective on it, because they say if you can improve health, you will improve the economy. Whereas many of us in the field say it's the economy, the failure of the economy, that is breeding the diseases. It's probably a little bit of both. And which one pushes the tail of the other, I don't really know. But there is a concern as our population continues to grow. I mentioned the pyramid, human population pyramid is changing with a greater bulge in the younger age groups. But what I want to point out is how that impacts on infectious diseases. So the number of people in the world, 6.7 billion, they are expecting that to grow to 9.4 billion. Now, why is that important in terms of infectious diseases? Well, part of it's where are they going to live? And urbanization for the last 50 years has exploded. And we're crowding more and more people into smaller and smaller spaces. That leads to the spread of communicable diseases. It's just a known biological fact. And these are the figures to back that up. So in 1950, not that long ago, post-World War II, there were only 10 cities on the face of the world that had a population greater than 10 million people. One of them was New York City, where I grew up. 1975, there's now 4 of those cities. And interestingly, 2 of the 4 are now in the developing world. Now, they classify Mexico City in that, and you could debate whether Mexico fits that criteria. But nevertheless, 2 of those classified as in a developing country. 2003, we jumped forward 27 years. We're now up to 20 cities with populations over 10 million. 15 out of the 20, or 75%, are in developing countries, where the poverty issue now is intermixing with increased population density, all leading to the spread of those communicable diseases. And you can see it's continuing, or anticipated to grow, another couple cities being added to that. You now add another factor. So we've talked about the population, behavioral issues, and now add in technology. Now, why would technology factor into this? Well, you only need to see this photograph and worry about avian flu, obviously, or the spread of certain diseases here in the cattle one, and you worry about Jakob Creutzfeldt disease, and we certainly had an epidemic from abnormal feed that was given to these cattle, and other types of population. But the main area where technology has added to the spread of infectious diseases has been the airline industry. And I only need to remind you of the one single individual who had, quote, was suspected of having multiple drug-resistant TB here from the U.S., who flew around the world and had CDC chasing after him and everyone else because of the fear of spreading that particular disease. But the numbers are amazing. I mean, when you pull out these statistics, I'm in awe of them. Distance and speed of travel has increased 1,000-fold since 1800. Each year, we have 1.4 billion people in the air. Global trade of food, animals, and plants happen overnight, anywhere in the world. So what kind of diseases would you suspect? Well, I don't think I need to worry about obesity from this, or even diabetes. What I do worry about is the spread of certain communicable diseases. I'll give you one case in point. Monkeypox. We've never had monkeypox here in the United States. And then lo and behold, here in 2003, you've got the headlines, officials scrambling to contain monkeypox. All because of the importation of these pets from Africa that were infected. And people were buying this. This was an outbreak that occurred Madison, Wisconsin, I think. It was Wisconsin, and Milwaukee, I think, was another hot spot for it, affecting children. Usually they're the sentinels for these diseases. This one, how many of you know about our imported Lassa? I don't know how CDC buried this. I honestly don't know how they buried it. I think they really were afraid of spreading huge terror around the U.S. But this is a true case. 48-year-old Liberian-born businessman, 5-year resident of the U.S. He works, grew up in West Africa, works there, goes there very frequently back and forth between Liberia and Sierra Leone, where Lassa fever is endemic. While there, he develops onset of fever, chills, sore throat, diarrhea, and back pain, but needs to get home and hops on his plane. 2 days after coming back to Newark, New Jersey, he takes the train back to his homes in New Jersey and is hospitalized within a day in Trenton. He then gets worked up. The leading diagnosis was malaria or typhoid fever and was put automatically on broad-spectrum antibiotics, worked up from the malaria, died several days later of adult respiratory of ARDS, which is a respiratory distress syndrome, complete whiteout of his lungs. And it was only on post-mortem that they made the diagnosis that he had active Lassa fever. Now, Lassa fever is not communicable through respiratory secretions, fortunately. But nevertheless, it is contagious through bodily fluids and blood. And so CDC did a very intense but quiet investigation. It's actually published in MMWR, and I just happened to pick it up. I don't know why the press never picked up on it, because Lassa fever is like Ebola in the United States. It is very, very scary and can lead to a very high mortality, as you could see. Now, I thought I'd show a couple quick snapshots because, this was a concern back in the beginning of the 21st century, and that was this initial outbreak of West Nile virus. So these are neuroinvasive cases, official cases that are reported to CDC. And it just, we never had West Nile in this country. And then lo and behold, boom, here it is. Diagnosis is made in New York, probably linked to an airplane that came, released some mosquitoes. They bit birds, the birds spread it, and you start to have a little mini epidemic. Now, it is spread through the arthropod vectors. The birds themselves are the primary host, and humans the inadvertent host for this disease. But watch what happens. Some of you in ID know this, but it's a fascinating series when you start to do the time lapse of the disease marching across the United States. And then we have a whole endemic situation. By 2005, in 2006, the entire United States, every single state reporting cases. Remember, the first case was in New York City, fall of 1999. So it only took several years, and it was the birds flying across the United States, our fly zone, if you will, and we'll come back to that for influenza, that led to the spread of this with over 27,000 cases, officially diagnosed, reported, with over 1,000 fatalities due to a disease that heretofore did not exist in the United States. Truly remarkable scenario showing how these diseases can crop up and rapidly spread in the population. Now, I mentioned earlier on that climate change is having an influence on the spread of some of these diseases. And certainly malaria and other commonly described diseases are benefiting for their spread. But if you're really, and we don't have time to go into them all, but if you're interested in one of the most fascinating articles is this one that just came out in Nature. In fact, John Bartlett, the other one, at ICAC IDSA listed this as one of the top 10 publications. He does this all the time. But it was I who would suggested he read it. He doesn't read Nature usually. And I had seen it, and I thought it was actually quite fascinating that they did this survey, and it actually was a publication survey looking at reports of emergence of infectious diseases between 1940 and 2004 that had hit publications. They counted 335 new diseases that were newly reported. Of interest, as you scope down into this, over almost 2/3, 60%, were actually from zoonoses, which is the interaction of humans in close contact with animals as we move through previously uninhibited or unpopulated, human-populated areas. Some of you may have read just 6 months ago, I was out gorilla trekking, have some great stories about that. But after I got back, they said that they just discovered something like 200,000 gorillas in the middle of Africa where no one had ever been before. Do you remember these reports? Yeah, 200,000. We thought they were becoming extinct, but here we just hadn't been there. Well, it turns out now they're trapping them. They're doing the bushmeat. It's this human interface with animals that will likely lead to probably some other heretofore undescribed infectious diseases that have come along. I think the one that fascinates me the most, that actually I have used in teaching to MBA students as an economic exercise of how a single infectious disease can unravel a sector economy within a matter of weeks to months, is SARS. And what it did to Canada, Hong Kong, and China is truly remarkable. For a 6-month period, their economy looked worse than ours does right now. They had an immediate hit on development of a recession. Tourism dropped to zero. Actually, Japan's economy actually increased. And when they did an examination as to why, turns out Japanese are one of the biggest tourist populations. They travel everywhere. Well, they were scared to leave their country, so they stayed. They actually had the fewest amount of travels, and so they spent their money in country, and they did really well. So SARS has some very interesting fascinations in terms of its impact on the economy. But I bring it up because it clearly illustrates how important surveillance is. Because if we could have picked this disease up and immediately done public health restrictions, quarantines, we might have been able to limit even the direct effects that it ultimately had. But most of you know it was one individual. He came from China. China was already having an outbreak of SARS, but they didn't tell anyone. They didn't know it was SARS. It was just a lot of pneumonia cases. But this one individual came for a wedding at the Hotel M in Hong Kong. I actually went to his room just 6 months ago when I was in Hong Kong, and the room's no longer there, quote unquote. The room's there. They took the number away of the room. So guess what? Do you all know what the number of the room was? It was 911. He stayed in 911. So you go up there, and here's 910, 912, 913. They just removed the number from the door. 912 is still the same room, 911. They just figured, well, we can't use that number anymore. But what happened? Look at this. All those people then went to different areas of the world and spread the disease. And you end up seeing an epidemic that looks like that. And ultimately, you end up with 774 deaths in a 6-month period, over 8,000 infected people, in a tanking economy in the Far East as a result of it. But it stopped. It's amazing. And it's incredible what academic centers could do with this, because we were able to identify the cause of this particular unknown disease within a matter of about a month. Once all the resources, they had what, daily calls at WHO. It was an absolute amazing collaborative setting of scientists working with epidemiologists that solved this problem and immediately put quarantines in effect. I happened to be in Canada when their quarantine went in effect. I didn't think I could get out of the country because flights between Toronto and Baltimore were shut down. I was on call and coughing, and so they were wondering, did I have it? They wanted to isolate me for a couple days before I could see any patients. So very interesting, a lot of lessons that we learned from it. One of them has been in diagnostics. This is an aside, it's not part of the talk, but I told you it took about a month. Well, because of biodefense, DARPA funding, NIH funding on surveillance and diagnostics for detecting unusual pathogens, an instrument has been invented, I guess you would say. There's 5 of them in the world. I happen to have one. Doesn't belong to me, but it's at Hopkins, and we're able to use it. We took one of these specimens from a SARS patient just to test this instrument out. We put it in. It does PCR amplification. It uses a mass spectrometer that measures the weight of the ATCG and then puts it in a 3-dimensional match, and then you put it into your computer database of all the sequences of all known bacteria, viruses, and fungi. And as long as there's partial sequences in the database, usually it will pinpoint. Within 1 hour of taking a respiratory specimen, putting it through this machine, it said this is a coronavirus, and it put it in the right family, and it said it is, we knew now in retrospect that was the family that caused SARS. So we now have instrumentation that can actually do this. It's not cheap. The instrument costs $1 million, but it's fascinating what it can do. And it can actually, I can take respiratory specimens, pop it in, and it will tell me what hemagglutinin and what neuraminidase the influenza virus has. So it'll say this is H5N1 or H1N2 or whatever it may be. So because of these diseases, technology keeps moving to help us in early surveillance. Obviously, bird flu is the one that scares a lot of people. It has sort of subsided from the public press. I guess you all know that. But I hope you've all gotten your flu shots for this year, mainly because seasonal flu is really the biggest threat, not avian flu for the time being anyway. And obviously, you can see the impact that it can have in each season as a result of that particular disease. But I bring up avian flu because I want to show you once again, in just a matter of 3 years, starting in 2004, and I'll end in 2006, you can see the outbreaks of avian flu spreading across all of Asia and then into Europe and parts of Africa. So it didn't take long for avian flu to explode outward. Hong Kong is the only place that they saw a couple dead chickens, they checked it out, and they immediately culled the entire population of chickens on the island of Hong Kong, and actually there were no more cases for the next 3 years. It's that kind of surveillance and action that can limit the spread of these diseases. Obviously, China did not do that, nor did Thailand and some of the other countries where it really exploded. But the scare is, what impact does that have ultimately on human cases? This is just a graphic showing what it was at the end of 2007. Last night, just to update you, I looked it up. It's a total now of 380 WHO laboratory-confirmed cases of human cases of avian flu, and we're now up to 260 fatalities. So the clock is ticking. cases are still occurring. It is not gone. And once again, we need to be vigilant, especially in this area of the world, as to whether it will evolve or change. One more factor I wanted to put out there, which I think for HIV/AIDS, and in this case for polio, was disastrous. We almost had polio eliminated. Not 100%, but we were doing pretty good with this disease. And then a group of religious people in Nigeria said this vaccine was a Western plot to limit fertility, and told their people, do not have your children vaccinated for polio. And what happened was that it totally reversed the whole course of our progression of limiting the spread of this terrible disease. And now we're just only now trying to recover from this. And people in the World Health Organization, EPI, other groups doing heroic jobs trying to limit polio spread. But it shows how quickly something can unravel if you don't have the political support of the country's leaders to limit the spread of that disease. Now, Mike knows I can't give a talk on infectious diseases without mentioning the disease that the two of us have shared a great deal, and that's HIV/AIDS. But I don't want to go into any detail because you've had plenty of talks about it. I'll just give you a couple vignettes about it. So I started working on AIDS as soon as it was recognized, 1981. And you only need to see this one photograph. This is from the cover of New York Times magazine on one Sunday. To really... So the first one with Peter Piot was in Lancet, and then we did a major paper in Science on the epidemiologic paradigm of AIDS in Africa, and that was 1986. And when I go back to look at that paper and what we said, we never knew that it would go up to 80 million people being affected. We thought this disease could be limited in its spread through the right interventions and the right actions, but instead we end up with curves that look like that. 96% of AIDS cases occur in low and middle income countries. 1,000 are in children every day, 1,000 new cases in children under 15, 6,300 a day in adults age 15 or older, half of which are women, and the disease continues to march through. Now, I met with some of the students today, and I said that I had one very depressing slide. I said there's a lot of depressing slides in this talk, but this is, for me, the most depressing slide. This is from 2007, 2008. It was presented. This is data that was presented at CROI, our annual meeting for HIV/AIDS. And it was from a British group working in KwaZulu-Natal, a certain region. And this is the HIV prevalence in men and women by age group. And for me, working with AIDS in Africa in 1983, seeing 5 to 10% prevalence rates was very scary. I never, ever would have anticipated 50% of young women being infected between ages of 20 and 25, or men up to 40 to 45%. It basically, again, I show this again because of the lack of political will in the Republic of South Africa to limit the spread of this disease. It's been a dismal failure. Whereas other countries like in Uganda, in Kenya, Ethiopia, political leaders have stood up. They have tried to implement interventions that have limited the spread of that disease. And where it has hit the hardest has been in the heart of the southern cone of South Africa, reversing life expectancy in those 5 countries. But HIV/AIDS brings along a partner in this epidemic, and that's tuberculosis. 9.2 million new cases occurred in 2006, 700,000 in HIV-infected people. Concerns about multiple drug-resistant TB, 40,000 extreme drug-resistant TB cases estimated. Absolute disaster when it comes to TB. And this is my snapshot, which I got from Stop Tuberculosis. This is the map of the world by case rate for TB incidence. And this is 15 years later, and the legend's off to the left. You can see the area that was most severely affected by TB was Africa. It wasn't the United States. We're still in the white. It wasn't even really Russia or even China. It's really focused where the AIDS epidemic has been the worst, and that's why the two diseases go so hand in hand. How are we doing in our fight against tuberculosis? Really pretty dismal. I don't think we've made any major advance there. We're still using PPD as our diagnostic. I mean, here I can diagnose SARS agent in 1 hour, but I can't pick up tuberculosis unless the person is actively shedding. But you can't pick up asymptomatic tuberculosis without doing PPDs and then debating whether they need to be on INH prophylaxis or not. Our drug regimens are really outdated, and the vaccine work is going on, but we don't have anything. BCG sort of put off to the side. We really have to worry about extreme drug-resistant TB. Where this is the worst is actually in the same area of KwaZulu-Natal with those high prevalence rates of HIV. The fatality rate of the people who got extreme drug-resistant TB within a matter of months was 84%. 84% fatality rate. You might as well have Ebola in this case. I mean, that's how bad the situation was. Malaria is added to this as another complex issue for Africa, but many other areas of the world as well. These are the obvious statistics that most of you have seen. 1.5 million deaths annually, mostly in children. This is the disease that got me going in my global health career, and I'm still fascinated by what is being done to try and limit this. There are at least 5 different vaccines underway. Rapid diagnostics have been developed that are better than the thin smears. So I actually think we're making more strides in diagnosis, treatment, and perhaps prevention for malaria than we have for tuberculosis. Then I mentioned the neglected tropical diseases. Here is a list of the ones that we talked about. Notice I got trachoma in there. Burden, its main burden are disability-adjusted life years lost. It's chronic morbidity, not mortality, that is related to that disease. And all the schistosomiasis, filariasis, trachoma, whatever, are overlapping once again with the other 3, malaria, tuberculosis, and HIV/AIDS, making it more and more difficult in some ways to mount an effective response against all of those diseases at once. So I want to end up with the response. And I'm going to do a couple different aspects of the response to these diseases. The one that the UN takes on as our, quote, global watchdog, if you will, has been the Millennium Development Goals. And we're halfway towards those goals, theoretically, in the timeline. And a lot of you probably don't read these goals, but number 6 is really the infectious disease Millennium Development Goal. And basically, every country is supposed to have halted by 2015, begun to reverse the spread of HIV/AIDS, so they singled that out. But they also say you should have halted and begun to reverse the incidence of malaria, tuberculosis, and all the other major infectious diseases. The question is, how well are the countries doing? I can tell you most of the countries in Africa are not meeting their goals. HIV, especially in South Africa. But they're there as goals, something that we can try to respond to. In terms of childhood infectious diseases, we actually have the tools, and that's vaccines, for these very common diseases. Pneumococcal vaccine, it's fantastic. Haemophilus vaccine, wonderful vaccine. Even rotavirus, which got a bad rap for intussusception, is actually a life-saving vaccine. The problem has always been in delivery and getting them to the populations that need these vaccines. Some places, it's working. When you can get these vaccines into the populations, they can have tremendous effects. What about HIV/AIDS? And here, I bring this up because this is where we all have common ground. Everyone reads about this in the paper every day. Here's our list of the FDA-approved drugs. All right? 5 of these are commonly used in Africa. And they're making a world of difference. And those of you like John and others who have worked in Africa know the impact just 5 of those drugs can have. In the U.S., it's reversing the mortality dramatically, saying AIDS drugs have saved 3 million years of life in the United States. And it was in 2000 that we actually saw true global health at its roots. And that was the inequity between treatment for AIDS in this country and Europe versus the lack of treatment for anyone in Africa. That is what global health is all about. It's changing that equation. You can't have that inequity if we're to live as a global society. So here were the outrage, and look what happened. Here's that year 2000. Look what happened. All of a sudden, we're up to $10 billion donated every year. I mean, I know Mike would have liked to have been head of GPA here. But it is amazing the turnaround that happened. And to be honest with you, I'm not exactly sure why it happened. Why didn't it happen 10 years earlier? And I don't know. Something changed in our society, and I mean even American society, to factor this revolution in trying to make a difference for people who live overseas, suffering from these diseases. Now, we can all criticize our current president, but where we have to give him credit, even when we do criticize him, it is in PEPFAR. And what Congress and he enabled many of us in this room to do, and that was to bring life-saving treatment to many people throughout the world. PEPFAR 1 was $15 billion. Those were its goals. According to them, they met every one of those goals at the end of the 5-year period. These statistics come from the United Nations, from UNICEF, as well as WHO. They're not coming from the U.S. government, yet we did make the 3 million mark in developing countries for people being treated for HIV/AIDS. Where we have been slow for the pediatricians in the group has been getting life-saving treatment to pregnant women who are HIV positive, which will prevent transmission, but will also help the mother. It's going up, but as you notice, only 1/3 of estimated infected women are receiving antiretroviral drugs during pregnancy. So we have a long ways to go. Now, I want to get into a debate, and maybe we can talk about it later. And that is, does PEPFAR, or Global Fund, actually help vertical health systems or horizontal health systems, or both? Does it help for other diseases, or is it only targeted for HIV/AIDS and at the cost of just focusing on one disease, the other diseases get worse? I'll let you make your own minds up, but in Uganda where I work, John O'Merman with CDC implemented a package of care for every single HIV positive person, and when they hit 250 CD4s, they got antiretroviral drug. But before they got to 250, They got everything else. And he has published the results of this. It has truly reduced morbidity and mortality dramatically in Uganda. So you now know we have PEPFAR 2. It's underway. I don't know what the new administration will do about it. It has to be reauthorized each year, the certain amount of money. It's a lot of money in tough economic times. They went from the $15 billion to $48 billion for a 5-year plan. Expanded the number of countries, expanded the amount of money for tuberculosis and for malaria, and for the first time they used the word research and training in the legislation, which was forbidden in the first legislation. So we as university academic folks can get a little bit more engaged with PEPFAR 2 in what we do overseas. Now there's a paper that just came out this month, well last month, November 5th, and it's in JAMA, and this is the controversy. Are we spending too much money on HIV/AIDS at the expense of other diseases where we should be putting our emphasis? And again, I'll let you read the paper. I have my own personal opinions. But they say, you know, here are the stats. This is from their paper. Every day, 43,000 adults and children die due to 7 problems in the world. 5,000 of these deaths per day out of the 43,000 are due to HIV/AIDS. Okay? It's number 5 on the list. These are the top 4 causes of death. Should we be putting more money into these at the expense of HIV/AIDS or not? And then, of course, malaria and TB, which are part of the PEPFAR bill. Where I work, we use the HIV/AIDS money to hit malaria, tuberculosis, and to do these as well. Now, do we tell anyone we do that? Yeah, I mean, we do. But we can't sit there and let these things happen while we're spending money on this. So we're building health infrastructures and better systems with the PEPFAR money. We've built new laboratories there. We've have gone out and done counseling. We've built in new water supply systems. I honestly think you can take this money that's dedicated for these 3 and help with these. The cotrimoxazole is helping with this and this to some degree. So I actually disagree with this article. I'll give you my personal bias right now, because I think they're a little short-sighted that they're not really seeing the true benefit of use of the money targeted for these to help the others. But you're not going to treat yourself out of the AIDS epidemic, and we've now re-entered the era of HIV prevention modalities. And there's a paper in Lancet. It's online. It's not in press yet, which I told the students about. It basically says, it recommends, if we want to really address the AIDS epidemic today, we need to do universal screening of everyone for HIV, and anyone who's positive, they go on antiretroviral drugs now. No waiting. There's an editorial that goes with that article. But that article's a mathematical model. It shows what can happen to the epidemic if you do that. The editorial says this is the best and the worst of public health. And I won't say any more. I'll let you read the paper. But it's a fascinating scenario. And I know John and others are caught up in the debate. At what point should we be treating HIV-infected people? And if it's to block transmission, then you should do it immediately. If it's to help their clinical disease, then you go by CD4. Which one gets weighted more? And where? And at what cost? So President's malaria initiative has been a major successful response. I'll go through these quickly because of time. New drugs are being developed for malaria control, better vector control, diagnostic tests I talked about, and right now we have 2 trials. Mike would like to know that Lou Miller has 2 clinical trials of malaria vaccines underway in Mali. He actually goes to Mali 4 times a year now. Some of you don't know Lou Miller, but I know Mike does. He was not a guy to leave the laboratory, and now he lives in the field. It's really wonderful to see someone do that. TB is the one that I'm most down on, and I borrowed this slide from Tony, which comes from our NIH strategic mission on tuberculosis research. This was from 2006. I haven't seen really much development in the field, and I've already said that, so I'll skip it. So to summarize, we actually, as dismal as I counted infectious diseases come recurring and reemerging and getting more established, I actually do think we have made great strides in limiting the spread of these diseases. And each of these bullets are areas where we have really had huge successes. And the situation could be a whole lot worse if we hadn't had some of these advances. But it's clear that we have to keep pushing the envelope on some of these. So I'll bring it back to why I was invited here, and that is, why is infectious diseases and global health so important to discuss? And I think it's because global health has become so popular among the young and the old. Even us gray hairs get excited about it. But it is, you've got a school here that's the School of Public Health at UNC. Well, they renamed it. It's now the School of Global Public Health. Mainly because the word global says a lot about what you're trying to achieve if you're studying public health or practicing public health. To Mike and I, global health is more than just public health. It's medicine, it's nursing, it's economics, it's business, it's society, it's psychology, it's many, many other entities all interfacing with one another to solve problems. Now, I think global health has also gotten very popular in its attention on infectious diseases and other diseases, in part because of all of these parameters. One has been increased funding sources. The Gates Foundation, new global initiatives like PEPFAR are really pushing the envelope on what we can do in developing countries and making a commitment to build infrastructure to conduct research and provide clinical care and to improve the life and the health of the people living there. These are some of the other things that are sort of bolstering the interest and activity in the field of global health. So I thought I would put on my hat from the NIH. I didn't know Mike Frank was going to be here, but I pulled this actually from one of the extramural groups at Fogarty. And it looks at how much money we're spending as an NIH, National Institutes of Health, getting their $28 billion, which has been flatlined for the last 5 years. Despite it being flatlined for domestic funding, you can notice that direct foreign research awards have been going up for the last 5 years, as have foreign components of domestic awards. They're not a lot of money, but they're growing. And I actually think that trend will continue. So almost by law, and I don't know if it's a law, we don't spend more than 10% of the entire NIH budget for international research. 10% is sort of the number that is often utilized. And you can see we're not, even if you add these three together, you're not quite at the 10% mark at all. If we look at NIAID, where I am, and I oversee the intramural portfolio of international research, you can actually see it parallels the Institute's flatline funding. All of you know NIAID's been flatlined for the last 5 years. So is international research. And here I give it in the percent. So we're less than the 10%, but not too much less. And it seems to be. But what was interesting is if you go back to 97, it was only 4%. So there clearly is a change and more investment in international health. Let me just. Now, I wanted to just close with one other point on the funding, and that is we have shifted the regions where we spend international money. Our research dollar, this is U.S. taxpayer dollar, and this is each of the different regions. For the Near East, because they've gotten richer than we have, it's gone down. For Europe and Eurasia, and that's been mostly Eastern Europe, it's actually gone up as the AIDS epidemic has increased there, as has many other issues. South and Central Asia has been pretty much the same across. East Asia and Pacific did go up in the early 2000s, has sort of remained level. And we have seen ups and downs in Africa depending on research initiatives. What's interesting, where we live, it is actually, for Latin America, our neighbors, it's actually going down as some of those countries have picked up the ball and run with their own internal research initiatives, like Brazil. In the 80s, that was a country we spent a lot of money. That has shifted over to Africa. So to summarize, from the NIH perspective, we are making an investment. The regional trend is moving away from the Western Hemisphere towards Eastern Europe, Asia, and Africa. NIH trends towards a rapid increase in international research funding with direct foreign awards now going. And we are developing a wide array, and I know many of you who are part of IMPACT or HPTN or HVTN or even CHAVI or many of the others are looking at these networks and how we support international research through the network support. So I wanted to thank you all for staying as late as you have, and I want to close with a quote. The quote comes from a controversial person who was actually fired from his job, but the transition team has picked him up for an economic as an economic advisor. I'll let you decide who you think that person is with this quote. And it's an interesting quote from a person who was fired from his job. There is no other area of human endeavor in which the application of thought and resources can make so profound a difference in as many people's lives as in the world of global health and biomedical research. Larry Summers was the person who said that, which I find quite interesting. As I said, a controversial person. But with that, let me thank you all for coming. Let me thank Mike for inviting me to join you today. It's been an absolutely very informative and exciting day for me to learn all about the Institute of Global Health here at Duke. And I wish you all great success in the future in your own endeavors, and particularly the future of the Institute. Thanks, Mike. Thanks, everyone.
Can take some questions. Tom has covered brilliantly the field of infectious diseases. If those of you had any doubts that they were going away, it's like when they said we'd have an AIDS vaccine, right?
Yeah, that's nice.
In 80, what was that, 86? When did Heckler make that?
86.
Yeah.
Yeah.
Okay.
It was the same kind of prediction.
So we want to get these circulated to Mike for the questions. So if you raise your hand. Okay.
I just thought it was interesting when you showed the international expenditures. The line for training didn't seem to go up at all, and I just thought that was interesting. If we're spending more on resources for people to do research studies, who's supporting the training for the international people?
It's a great question. Fogarty is still committed, but they've not been allowed to increase because of their congressional budget. It's a big mistake. I actually 100% agree with you. We need to do more of that training. We need more funding to take our own students and send them over, and vice versa. The good news is PEPFAR 2. PEPFAR 2 has put a lot of money into human resource training in country. It's something like within the next 5 years, we are to train 150,000 healthcare providers with the money in PEPFAR. So someone, whoever wrote that legislation, put that in there realizing the problem. But it's going through the PEPFAR legislation, not through HHS. Remember, PEPFAR goes through State Department. So, you know, it's a little disappointing. The IOM also has come out very strongly with what they would like is a health Peace Corps type, or health corps. People of the U.S. with expertise and training going abroad and spending a year to 2 years over there. And that's what we tried to do with the Academic Alliance. We built a facility, a training center. We've now trained 3,000 healthcare providers in the last 4 years. And who does the training? We bring people who are volunteers from the U.S. to live over there for a month or 2 months. John Bartlett's been there. You saw the facility, I think, IDI. Yeah.
I'll raise one question, Tom, you might be able to speculate about. You showed the Nature paper. You mentioned the Nature study, and the thing that constantly perplexes me about the global health is why we can't get veterinary public health to rise to the fore here. We have a great vet school in this state, which actually is quite committed to global health. We've been very impressed, as there's one in University of Washington, as you know. But the issue of how to deal with emerging infections and infectious disease in general is so linked to veterinary public health, and yet NIH or any of the major funding agencies, it's just not there. And most people who go to vet school, they want to take care of cats and dogs. And so the question is, how do we make veterinary public health? Do you see, since you're at NIH, are there ever discussions about this? I mean, that paper has again shown the dilemma we're in, but where's the science behind doing something? My understanding, for example, in avian flu, is that we could, if we had the science and the resources, we could do so much more to prevent a pandemic by dealing with the animals than with humans. It's going to cost much more to deal with humans. So I don't know if you want to comment on that, or if you know why this field just doesn't get the attention it needs.
Yeah. We're reactionary. NIH wants to support basic bench research, but when it comes to these types of, the example you brought up, avian flu, so that's a reactionary kind of thing. So they'll put out an RFA for vets to work on avian flu. But that's not helping the rest of the field. And I have not heard in the corridors there, but I'm not that close to the extramural environment, why we're not increasing support for more veterinary medicine and surveillance of diseases. We would probably know a whole lot more about Ebola or Lassa and others if we had done that. It's even tough to get money for the primate studies for an AIDS vaccine. Kent probably knows that more than I do. And with flatline funding, we had the vaccine summit where priorities had to be set. And I'll tell you, they did not feel there should have been an increase to the veterinary arena for the HIV vaccine. Yet we can learn a great deal from them. What instead it looks like where the emphasis will go will be in supporting junior faculty, young investigators, get new ideas. And if they happen to come from the veterinary field, I think they could stand a good chance in doing it. There have been Chris, blocking on his last name, he's a veterinary scientist in HIV, AIDS, and primates in Davis. Chris Miller. He's done great. If they come up, it's no different than academic medicine. You come up with the right idea and know how to write the right grant, and it gets scored well, you'll do well. The problem is with flatline budgets and salaries to pay and other things, The average age, I heard, of getting a new R01 is in the 40s. First R01. Yeah, yeah, 40s. That's not helping the young investigators. And hence, that's what came out, I heard, out of the vaccine summit. We've got to change that paradigm. So we'll see.
Could I just quickly respond to that?
Oh, yeah.
Just comment about this. I went to a conference last year on biodiversity to health that was largely veterinarians and ecologists, and they made a very similar comment, but about doctors. Why aren't doctors concerned about these things?
Well, two of us are.
Exactly, the
Yeah.
link between human health and animal health. And I think there's interest. There's just not a lot of talk going on
No,
between
right.
the medical
Yeah.
and veterinary professions. There's a conference right now going on in Mexico, the EcoHealth Conference,
Yeah.
that's trying to bring together some of these doctors and veterinarians. It's just not happening. I don't know.
It's a good comment. That's, crosstalk's very important. That, theoretically, and Mike will agree with me on this, that is what global health is supposed to encourage, is interdisciplinary cross-communication and collaborations. And it means medicine working with veterinary medicine, right?
Yeah, I just mentioned we're trying to form a consortium in the triangle of Duke, UNC, NC State, probably FHI, and maybe one or two other organizations to try to address that issue. NC State is great vet school and agriculture. In agriculture, we use issue also regarding nutrition and foods and particularly the food crisis right now. Foods and yet there's, we have a chance here to do this in the triangle, and we're going to try. The question is whether we can bring these universities together. Forget basketball, probably we can do a pretty good job.
Yeah.
Can't forget, you can say that.
Hey, the state of Washington, actually, so they have a veterinary school, state of Washington, and they just opened a school of global health, veterinary health, School of Global Veterinary Health, and they are linked to the Seattle Department of Global Health, and they are trying to do crosstalk and trying to, yeah, it's not happening at Hopkins. In fact, the one person, we don't have a vet school. Maryland does, yeah. And the one person we had who was unbelievable in doing these emerging zoonoses, it was just a growing faculty member. He was having some trouble getting some of these R01 grants and so forth. Got a great offer to go out to California and now is leading their emerging infectious disease group. He works with the veterinarians out there. He's perfect, and we lost him. It's sad to see a star like that leave. It happens all the time, and no one has filled that void.
Thanks so much. I was actually intrigued by your discussion of the Denny Emmanuel JAMA paper, the 7 causes, and
Yeah.
the PEPFAR
Good.
ones are at the
I was
bottom.
hoping someone would bring that one
Yeah.
up.
So my question is probably pretty basic, but why is it that way, and why is that happening? And first of all,
Why is what happening?
why does PEPFAR exist and not something
Yeah.
for the top 4?
Right.
And ultimately, I think it's a question of political will. So first of all, what can be done to generate political will for the top 4 so you can stop taking money from the bottom 3 and bring it up? Second of all, is that even necessary? Or are you finding the current model you're using of just building broad infrastructure workable enough that you don't need to really start up the whole politics all over again?
Great question, and difficult to answer. Actually want other people to try and answer it for you, but I'll just give you my bias. So one is, I do think we should be investing in health, not just 3 diseases, but other diseases that prevent health. And I think it would be a great way, if you remember my Lancet slide that I showed, that health is one of the most important parameters of foreign policy these days. I actually think we could get a lot of traction. Now, I have talked to the Obama transition team, and they are not going to put money into this at this time because we're in an economic crisis within our own country, and to be pouring billions into Africa right now. He wants to do that. He's got heritage from there. But I talked to his health advisor. They said they've got to focus on the domestic health policy situation. They got to focus on the economy. I am not expecting any increases from the U.S. government for international or global health initiatives. We're going to have to rely on Gates and others and go the course. Now, I hope they don't cut back on the PEPFAR. And as long as that money is there, I will continue to use it to address the other parameters. And I think you can do that. If we're going to train 150,000 healthcare providers, we're not going to just train them in AIDS. We're going to teach them about all the other things and get vaccines out there and, you know, many of the other issues. We're doing HPV vaccine studies where, you know, I honestly do think right now we're in a stuck situation with the economy the way it is. And I think we just try our best to make the money stretch to address those other health problems. So I don't want to join that debate right now because I know I don't think we're going to get much traction. I want to support PEPFAR too. Now, I do a lot of AIDS stuff, so I'm a little biased, but I do think we can improve it. Now, I have people I work with, and they say it's created a false economic sector in the developing countries, that it's taken primary health care people that were doing good jobs, family planning and other things, and the money is in AIDS care. And so they've left, and it's created a humongous void in that health care delivery. And that's the downside. That's what Ezekiel Emanuel, I don't know if you know him, but he's an ethicist. But that is why he wrote the paper. He saw that, he heard that, and he said, we're creating an unequal setting of health delivery in these countries, and we need to change it. So you can argue both sides of this, but until the emphasis and the money behind the emphasis changes, I'm going to try and do as much as I can with PEPFAR too, where I work.
Yeah, my question is related to the war in Afghanistan and Iraq. So have you seen or any emerging diseases or like change in the trend of infectious disease in that part of the world?
I haven't, but I'm not quite sure if the surveillance is all that. Or that they would tell us, right. I think we're going to, I mean, something could emerge there, clearly. You know, it was interesting. After we ousted the Taliban years ago, actually heroin, opium exportation, increased tenfold out of Afghanistan. It created this economic shift in the economy. And, well, you know, how it's impacting on health, I don't know. The only one I know that I've been monitoring closely is the Congo situation, the war going on there, and that's very bad. We are seeing a lot of childhood fatalities. We have a team there from Hopkins right now, and I'm scared for them because just the way it's so volatile. So there are diseases that are emerging, but they're the known ones that we see in displaced people. Afghanistan, I honestly don't know what's transpired there. Good question.
Tom will stay, I'm sure, a few minutes after. Let me thank you again, Tom. I will say that this debate on the future of global health funding is going to continue. I suspect other speakers are going to have to address this. This is going to continue. Your question is going to continue for the next 3 to 4 months as things play out in the Obama administration. I mean, the $48 billion, we have to remember the AIDS money is appropriated, not, authorized, and not appropriated. So there's a big difference in the Congress between authorization and appropriation. And so the real question is going to be, as Thomas pointed out, will we even get that money appropriated? And so it's not, right now, while if you were starting over and had a different economy, you might handle that paper one way. But right now, those of us in global health, we don't want to lose the gains we've had. And frankly, I think they're at great risk right now. But I think we'll have to play out over the next few weeks and months on how this is going to go. And it'll be interesting to follow this through the seminar series, because I suspect this is going to come up quite a bit. So, Tom, thank you so much again. Thank you all for staying. And I'm sure Tom will stick around a few minutes if you have any questions. Have a good evening.